Welcome back to the Awesome Physio YouTube channel. Today we're going to be talking about why am I getting pain in my groin. So what causes groin pain? What are the most common things that we see in clinic? So probably one of the most common acute onset causes of groin pain can be linked to any high impact sport. So either high intensity with football or anything where you're twisting and turning into that lower extremity. What typically happens is it normally is impacting your adductor muscle. So your adductor longus, which brings the leg in. The reason why this is impacted is it attaches from your pubic symphysis down into the linear elbow of your femur, so coming down, and can be most commonly aggravated if we're suddenly fixing the leg in a position and we twist away, or we go into a tackle with football, or it suddenly slides away. All these different positions, that sudden acute stretching of that muscle can cause pain, again along the muscle belly, but typically right up into that groin area, normally on the inner side. People report after they've had it that it's normally quite localized, quite specific in terms of sharpness up into the groin, more inwards towards that pubic symphysis attachment or pubic rami. What we also find is any kind of stretching, so when they try and stretch it out after, or they load and move in that leg after, so any kind of normal movement tends to really aggravate, so very, very specific. The other one that we would look at with this, that's the adductor longus, is the iliopsoas tendinopathy or the iliopsoas strain. That's a lot more kind of lateral, and that's typically involved in hip flexion, so any kind of kicking exercises, so again could be related with football as well, will typically present with that really specific groin sharpness and pain, normally worse on lifting up through the legs. So if they're going up and down stairs, or different movement through that leg can cause a lot of pain around that attachment into the pelvis. And again, what they report is it's very sharp, very specific, particularly if it's come on with an acute onset, and that helps us as clinicians to differentiate whether it is a chronic tendinopathy, so wear and tear microtrauma over time, or a really specific strain into those particular muscles. So what do we do about it? So the first thing is to have it assessed properly by a musculoskeletal expert, working out, what is going on, what's actually triggered in that area, because lots of other stuff can present in a really similar way. Second thing, you want to do that acute management, taking that pain down, so icing into that area can be really good to help reduce that soreness. What you would then look at with your musculoskeletal expert, whether that's osteopath, chiropractor, physio, is building that back up over time, because there's a fine balance of not wanting to overstretch the area, but also wanting to kind of bring it back to that normal range of motion. So what they'll do is tailor a plan where you can gently build up movement, stretching and strengthening over time, so that you're not aggravating, but you're helping that area to heal. The next condition that we want to talk about is femoral acetabular impingement. So what that means is that articulation between the femur and the acetabulum of your hip coming together. It's a normal ball and socket joint. What can happen in certain individuals, whether it's a genetic predisposition or repetitively wear and tear over time, repetitive movements, is it can cause a change to the articular surfaces of the femur and the acetabulum. So what can happen in the CAM type of FAI, so femoral acetabular impingement, is you get a flattening or a changing of the femoral heads. In the pincer type, you get bony growth or changes to the acetabulum. So all that means is your range of motion and the mobility through that hip is significantly altered. What people typically present with, particularly if they've had it from birth or it's part of their genetic history, is they might find that whenever they've done sports, their hips have always been quite limited. They've always struggled to get that full range of motion. It's always felt quite stiff, quite sore. And what they find is when they're bringing the leg up and typically in, although it can be painful as you turn the hip outwards, it tends to pinch or become really sharp. So it's quite specific on movement. So when you have your hip assessed by a musculoskeletal expert, what they'll find is that the movement or the quality of movement will be limited in that hip. So it's really important to work out if you have this, if you're struggling with groin pain, as what studies have shown is if you leave it, sometimes it can predispose someone to have hip osteoarthritis as well. So the classic presentation that we might see in clinic is certain weight bearing movements become really sore over time, certain positions, they just feel like it's catching in the hip, and like I said earlier, they're prevented in doing certain movements. So in terms of management of this, we need to identify what's going on in the hip. So you probably want some kind of imaging into the hip to see what's going on with the articular surfaces. You then want to assess all the musculoskeletal structures around to see if there's any predisposition or aggravated tightness in different structures that might be making the symptoms worse. And then what the expert will do will be coming up with a really clear plan for you so that you know exactly what's going on and what are the best rehab exercises and prevention steps moving forward. Finally, we're going to be talking about hip osteoarthritis. So as I mentioned earlier, it can be predisposed by other conditions. So if you've had a history of really high impact, repetitive activity into the hips, or a history of impingement into your hip, sometimes, not always, that can impact the articulation of that joint, which can predispose wear and tear later, just from the excessive pressure and excessive load into that joint. What we typically find is people are older if they're coming in with hip osteoarthritis. It's normally been building up over time, so they might be reporting that over time the hip movement's just been getting a little bit more limited, a little bit stiffer. What we find is typically that they move in the advanced stages into a fixed flexion deformity, so they might be moving their body to help with the pain. So they might be tipping the body forward or turning the leg outwards, because what that does when we externally rotate or we flex forward is it tries to take the pressure off the joint surfaces. So the body adapts to help with pain. So you can normally see that. What we typically find as well, if they're avoiding weight bearing on that side, if it's painful, is we might have weakness in the supported musculature of the hip. So gluteus medius and minimus, gluteus maximus might be adapted. They might be going into a little bit of a waddling gait, again trying to avoid that movement onto that hip. So everybody's different, everybody presents different, but you normally start to see compensations that the body has done to help avoid that pain. So they normally present with morning stiffness, quite severe stiffness and restriction in the hip. It tends to improve the more movement they do, and then it might be getting worse during the day. They tend to struggle if we're thinking about, putting our socks on, stuff like that. It's anything that's flexing and pushing into the hip, so it can be really subtle changes that they present with, and like we said, weakness as well. So the best thing to do is obviously have it assessed, see what's going on, see what the movement's like, testing all the structures around, which is what we would look at in clinic. Any concern, particularly if it's advanced stages and really significant wear and tear, we'd want to send for an x-ray, want to send for imaging, want to see what's going on in that hip and make sure there's no other complications or issues going on, and then coming up with a plan moving forward, either in advanced stages, potentially a replacement into the hip, but again, that needs to be discussed with a specialist, or if it's quite minor, getting strengthening into the muscle around the hip, taking the pressure off and helping with that optimal movement. So the final point I wanted to talk about today, so obviously we've covered 3 different conditions that can cause hip pain. It's not that simple. There's normally lots of different stuff going on. So what you'd want to look at in clinic is ruling out any kind of insidious condition, so any kind of damage or stress fracture or any issues into the femur or into the actual hip joint. We'd also want to look at any hernias that might be referring pain into the groin area. So although we've spoken about musculoskeletal conditions today, you also want to consider other stuff that might be going on as well.